Hi, and welcome to the 2016 County Health Rankings Introductory Webinar. I'm Amanda Jovog, and I'm excited to share the new data, tools, and resources available to you on March 16th, our release of the 2016 County Health Rankings. I'm joined here by my colleague, Kate Conkle, who will be fielding questions and chatting out links throughout the webinar.
Hey everybody, it's great to be here.
Okay, so let's get started. We want to start by acknowledging that the County Health Rankings and Roadmaps program is the result of the contributions of many partners, including the Robert Wood Johnson Foundation, our colleagues here at the University of Wisconsin Population Health Institute, and the various partners who help us compile the rankings data and get the message out about the rankings and roadmaps. So here's our outline for today's talk. First, we'll take a quick look at the background thinking behind the County Health Rankings and Roadmaps program. Next, we'll look at what new features are available on the 2016 website. After that, we'll look at the 2016 measures and data changes. This year, you'll note an increased emphasis on the non-ranked or additional measures on the County Health Rankings website. We'd like to show you all of the 2016 additional measures and introduce several new measures. After that, we'll go to a quick wrap-up and hopefully leave plenty of time for questions at the end of the webinar. Please feel free to use the question feature in the GoToMeeting interface to send us questions throughout the webinar. Staff will be fielding questions throughout, and I'll be checking in for questions at intervals during the webinar. If you've participated in these annual new measures and methods webinars in the past, you'll note that there's a section we'll not be covering this year. Normally we discuss the math behind calculating the rankings and also explain some data issues such as dealing with missing data and data reliability. This year we've got a very full webinar, and so we will not be covering that section. However, I'd like to note that our ranking calculations methods remain unchanged from last year, and I want to point you to a relatively quick 20-minute webinar that we recorded last year that covered these topics. Kate will chat out that link during this webinar. Okay, I'd also like to note that since this webinar is pretty packed and we'll be focusing pretty heavily on what is new for 2016, we'll only be providing the most cursory introduction to the County Health Rankings and Roadmaps program as a whole. If you're relatively new to the program, I'd suggest taking a look at one of the 101 webinars that we offer quarterly. Kate will chat out a link to one done in January of this year. Or you can sign up for the April 5th 101 and website tour. That'll be a great way to help you get to know the new website once it's released. So let's get going. I'd like to start with a quick reminder of why we produce the County Health Rankings in the first place. This picture shows the thinking behind the rankings, our theory of change about how rankings can be a catalyst for action that improves the health of everyone in a community. We start with population-based data from a variety of sources. Then we use that data to rank the health of nearly every county in the state. Each year, the rankings release, which this year will be on March 16th, generates national, regional, and local media attention. This provides an opportunity for people to tell the story of the many factors affecting health in a community. Those communities use the findings as an opportunity to mobilize multiple sectors to look further at their community's strengths and needs. And based on this deeper look at their unique priorities, community members identify evidence-informed strategies that can be implemented locally to make change. Over time, these evidence-informed strategies result in longer, higher quality lives for all the children and adults in the community. Essentially, the County Health Rankings aren't all about numbers. They're all about a call to action. The rankings are a starting point for discussion in communities, not an ending point. Communities might want to dig into local data to further understand what's going on in order to know where and how to take action. With the County Health Rankings, each county across the nation receives two rankings. One is health outcomes, which is the current health of the community as compared to other communities within a state, and health factors, an estimate of the future health of your community as compared to other counties within your state. So health outcomes can be shorthand for today's health, and health factors are the things that matter to tomorrow's health. Okay, so let's take a look at the new features that will be available in this year's release on March 16th. This is a screenshot of our new front page, where you might notice a few differences. There's a new menu available on our top navigation bar. The Resources menu will offer quicker access to the numerous tools and resources available from the County Health Rankings and Roadmaps program, including items such as the Recent Health Gaps Report, our new Key Findings Report, and other background material on the rankings. So perhaps some of you have visited the Our Approach section of our website in the past. This year, you will notice an expansion of this section. As well as being able to access background information on all of the health factors in the County Health Rankings model, we've also provided access here to important information for all of the measures included in the 2016 rankings. Now, you can easily find out how each measure is calculated, why we include it in our rankings, where we get the data from, and important information about each measure's strengths and limitations. And from each measure page, you can quickly go to your state's data for that measure. We've also made some enhancements to the county snapshots. As you may know, in addition to providing the underlying data for all the measures we use to calculate the ranks, we also provide some additional measures. Now you'll be able to see both ranked and additional measures at the same time. We are offering this new feature to help ensure that communities don't miss the wealth of information available in additional measures. Later in the webinar, we'll be discussing why some measures are ranked or not ranked, as well as the new additional measures we're adding this year. Another new feature we're excited about is called Areas of Strength. For a few years now, we've offered a tool called Areas to Explore on each county snapshot. Selecting Areas to Explore highlighted measures where communities might want to focus their efforts. These measures had worse values when compared to the state or national averages. This year, you can also select areas of strength. Our team has used a variety of techniques to identify health factor measures for your county that seem to reflect areas where your community is having the most success. We identified measures where there are meaningful positive differences between the county's values and either the state average or the national average. Just a note, this is obviously some fake data here, but you should have this on your website on March 16th. So finally, we're also expanding the capabilities of our Compare Counties tool to allow for comparisons between counties in different states. This should be particularly useful for border counties whose adjacent counties may be in a different state. Okay, I hope those new features got you as excited as we are for this new release. We really think they're going to be useful in exploring your data as you dig into it when you see your new snapshots. So now we're going to review the ranked measures available in 2016 and discuss some changes in the way our measures are calculated. But first, I'm going to talk about how we choose measures to include in the county health rankings. So, how do we select measures to include? This is an important discussion to understand why some measures we have are, why some are additional measures, and why we don't include some measures in our data at all. Our criteria really fall into two categories: County Health Rankings and Roadmaps program goals, and technical feasibility. First, let's talk about how we select measures to support our goal to support communities' efforts to improve health. So measures need to reflect important aspects of population health that can improve. They need to be modifiable factors. The rankings are about data and communication, so it's important that each measure and its association to health can be effectively communicated to the media, to communities, and other key audiences. We believe that fewer measures are better than none. We believe that action is more likely if people aren't overwhelmed with too much data. We try to use our measures to speak to emerging health issues of importance that will bring current and new stakeholders to the table. We replace measures if we find ones that are more closely aligned with or provide better estimates of the underlying construct we're trying to measure. We try to keep as aligned with other metric initiatives such as America's Health Rankings as possible. And we look for measures that will advance efforts to address health equity. So we prefer if our measures can be explored for smaller geographic areas or for specific population subgroups within counties. Now let's talk about the more technical criteria. Since these are the county health rankings, we use data that are available at the county level. Lots of people ask why we don't include this measure or that measure. The most common reason is that it is not available at the county level. We don't collect original data ourselves. We use data that others have collected. Whenever possible, we use measures that are valid and reliable and have been tested and used by others. We try to make the ranks as applicable to as many counties as possible. So we don't rank on measures where data are not available for a large number of counties. We use the most current data available prior to our release. I'm sure that some of you share our frustration with the time that it takes for some data to become available, but this is out of our control. Each measure must be rankable, and by that I mean there must be clear best and worst values for that measure. So based on these criteria, we change our measures of key health factors if we find measures that reflect a better data source or a better way of calculating that measure, or more importantly, if we think they're really going to help us in our communication to communities about the different factors that impact health. If you're interested in a more in-depth look at our measure criteria, Kate will chat a link to our documentation on this topic. So before we look at this year's measures, let's quickly review the model that they arise from. This is the County Health Rankings and Roadmaps model. Our rankings are based on this model of population health. You see health outcomes in the top in green and health factors in the middle in blue. In health outcomes, we measure both length and quality of life, and in health factors, we measure health behaviors, clinical care, social and economic factors, and the physical environment. Now we're going to talk briefly about the actual measures we compile. I'll note up front that we've not added any new ranked measures for 2016, that is, measures that we use to calculate ranks for health outcomes and health factors for nearly every county in the nation. But there are important methods changes that I want to review. First, we look at the health outcomes measures. They're divided into two focus areas, length of life and quality of life. We weight these two areas equally since we believe length and quality of life are equally important. For length of life, we measure premature death, and to be more precise, years of potential life lost. This measure is central to our work because it carries the entire weight for length of life. It's based on deaths prior to age 75 with the belief that deaths under the age of 75 are premature and that many of them could be prevented. We also look at 4 measures of quality of life. Low birth weight, which we give a weight of 20%, and again, this comes from data collected by the National Center for Health Statistics from birth certificate data. Then there are 3 other measures we use to look at quality of life, and they all come from the Behavioral Risk Factor Surveillance System. There are 3 questions that are asked of individuals regarding how they feel about their health status, whether or not they're in poor or fair health, how many days in the past 30 days they felt physically unhealthy, and how many days they felt mentally unhealthy. We include these to stress the importance of quality of life and the importance of both physical and mental health. If you look closely at the 3 measures from the BRFSS, you might notice something different this year. In all of the previous releases, the CDC provided us with estimates based on 7 years of combined data. This year, the methodology used to calculate BRFSS measures has changed, and only 2014 data was used to construct estimates. I'll discuss these changes in some detail later in the presentation. Now we're moving on to the health behaviors section of our model. Here we include measures in 4 areas: tobacco use, diet and exercise, alcohol use, and sexual activity. We're continuing to use the same measures in all of those areas, although 2 measures, adult smoking and excessive drinking, are also affected by the changes in the BRFSS calculations. Our measures in clinical care remain unchanged. We measure access to care as the percent uninsured combined with population to provider ratios for primary care physicians, dentists, and mental health providers. Access to care is obviously very important, but so is quality of care. Here we're able to provide county-level estimates for 3 different areas, courtesy of the Dartmouth Institute: hospital stays that could be prevented with better quality outpatient care, diabetic monitoring, and mammography screening. Moving on to social and economic factors. If you recall from our motto, this is the section that actually has the highest weight overall. We assigned a weight of 40% to our measures of social and economic factors, recognizing the key role they play in the health of communities. We define this into 5 focus areas: education, employment, income, family and social support, and community safety. There's no measure changes for this section. In the physical environment, we continue to measure air and water quality, as well as housing quality and transit patterns. The only change in any of these measures will be our calculation of drinking water violations. In 2016, there will be a change in the meaning of this measure from the percentage of the population potentially exposed to water exceeding a violation limit during the past year. That was our measure in 2015. In 2016, our measure will be an indicator of the presence of health-related drinking water violations. A yes will indicate the presence of a violation in your county, and no indicates no violation. This new calculation uses the same underlying data. This change reflects comments we received about the reliability and specificity of the data we gather from the EPA. We no longer feel confident that we can correctly calculate the coverage or extent of a drinking water violation in a county, but we can confidently say that there was or was not a violation in the past 2 years. Just so you get a sense of how many counties had or did not have health-related violations, about 1,100 counties in the U.S. out of 3,140 some had no health-related violations. Now that we've reviewed all the ranked measures, let's return to the BRFSS changes that I talked about earlier. So here you can see the list of measures that are calculated for the county health rankings by the Centers for Disease Control and Prevention using data from the Behavioral Risk Factor Surveillance System. The BRFSS is a state-based random digit dial telephone survey that's conducted annually in all states, the District of Columbia, and U.S. territories. Measures in bold are new for this year, and all new measures are additional measures. So first, a little background on the reason for these changes. Historically, BRFSS selected a sample of participants based on landline telephone numbers. Due to increasing numbers of people who only use a cell phone, in 2011, the BRFSS underwent a major methodological shift to include cell phone-only users for the first time. That change in sampling meant that data from 2011 onward couldn't be easily combined with earlier years to create county estimates. For both privacy and reliability reasons, CDC does not release estimates based on the responses of fewer than 50 people. In the past, in order to get that many respondents in about 90% of counties, they combined 7 years of survey responses. CDC realized that in order to include the growing population of cell phone-only users, they would need to come up with a different method of creating county-level estimates for us. For the last couple of years, while they were refining this method, CDC continued to provide us with 7-year estimates, excluding all of the cell phone-only users from the sample. This year, for the first time, CDC provided us with estimates that include both cell phone and landline users. Using a modeling technique that incorporates 2014 BRFSS data with demographic characteristics, CDC has created estimates for these measures for all U.S. counties. These new estimates will look substantially different from earlier estimates for some counties. In case your county sees a substantial change in any of these measures, let's talk about why this change may be occurring. So, if you're a community where this year's value for a BRFSS measure has changed substantially from last year, what does that mean? Most of the time, one would assume that a change in measure value reflects a change in underlying behavior for the specified time frame. In the 2016 release, 2014 BRFSS data will be used. In 2015, combined data from 2006 through 2012 was used, meaning that we are essentially jumping forward 5 years. So it is possible that some amount of behavior change has happened over this time period. However, this is certainly not the only reason for estimate changes, and it's probably not the most prominent reason this year. Another potential reason is that the sample included in this year's estimates now includes cell phone-only users. One of the reasons cell phone-only users were added to the BRFSS sample in 2011 was that research had shown that cell phone-only users differ from landline users. For example, cell phone-only users are younger, they generally smoke and drink more, and so these differences may play into why your community's estimate changed. The other reason for any changes in estimates may be the fact that these estimates are modeled rather than drawn directly from sampled responses. In this instance, modeling means that a county's estimate is based not only on survey responses from people in that county, but is also based on the responses of other people who are like people who live in that county. In essence, the demographic makeup of the county can influence the estimate produced for the county. In large counties with many responses, the effect of this model will be relatively small. But in small counties with few responses, the estimate can be interpreted as how a county with the demographic structure of this county is predicted to answer. Overall, we have confidence that these estimates from the CDC provide a more precise and timely measurement of health behaviors than earlier methods. But like any measurement, there are strengths and limitations that people should be aware of. For example, one byproduct of this new modeling is that it produces smaller confidence intervals than you will have seen in the past. Perhaps the most important takeaway I'd like to leave you with on this topic is that counties should not compare the values from BRFSS measures in the 2016 rankings with previous values. We hope that the CDC will continue producing estimates using the same methods so that over time there will be BRFSS estimates that can be compared from year to year. So, we just covered some pretty technical information there in a short amount of time. Please take note that this webinar is being recorded and will be posted along with the slides later this week. Perhaps you might want to review this section after you've seen your county's new estimates. Also, don't hesitate to use the Contact Us buttons if you have questions. Now we're going to turn our attention to the additional measures. As I mentioned earlier, additional measures will have a more integrated and prominent place in this year's website. We decided to go this route in recognition of the important roles our additional measures play in helping communities understand their health. First, it's important to note that additional measures should not be considered secondary measures or measures that are less important than ranked measures. There are several reasons measures are included as additional measures. I'll outline them briefly now. Demographic measures are important for communities to understand the population who lives there. We don't, however, rank on these measures because there is no ideal level of what would be ranked best. For example, there's no ideal percent rural or percent female or percent Hispanic in a community. Some additional measures are there to provide another look at a type of data. For example, we include premature age-adjusted mortality as a partner to our ranked measure of premature death. For some audiences, age-adjusted mortality is a more understandable and accessible measure. As we get access to new measures, we often include them as additional measures for a year or two to better understand their usefulness to communities before adding them to the calculation of ranks. For example, data on insufficient sleep and new model data on drug overdose deaths became available this year and have been added as additional measures. Some important measures are only available for some counties. We make every effort to only include measures that cover the vast majority of counties as ranked measures. An example of this is our new measure of Black-white residential segregation. Due to smaller populations of African American residents in many counties, we were only able to calculate this measure for two-thirds of all counties, which isn't really enough to include as a ranked measure. Okay, so here you see the additional measures of health outcomes that we will provide this year. I'll talk about the new measures in bold in a moment, and more detailed information about other measures are available on our website. So our additional measures are premature age-adjusted mortality, child mortality, infant mortality, frequent physical distress, frequent mental distress, diabetes prevalence, and HIV prevalence. Our additional measures for health factors include food insecurity, limited access to healthy foods, drug overdose deaths, a new measure, drug overdose deaths that are modeled, motor vehicle crash deaths, and insufficient sleep, another new measure. In clinical care, we measure uninsured adults and uninsured children, healthcare costs, and other primary care providers. For social and economic factors, we measure median household income, children eligible for free lunch, residential segregation black-white, and residential segregation non-white-white, and homicides. So let's take a closer look at each of our new additional measures. Frequent mental and physical distress are measures that are both based on the same BRFSS questions as the two ranked health outcome measures, mentally and physically unhealthy days. Frequent mental distress is the percentage of adults who report more than 14 days in response to the question, now thinking about your mental health, which includes stress, depression, and problems with emotions, for how many days during the past 30 days was your mental health not good? Frequent physical distress is the percentage of adults who reported greater than 14 days in response to the question, thinking about your physical health, which includes physical illness and injury, for how many days during the past 30 days was your physical health not good? We are including these two new measures as they provide a slightly different picture that emphasizes those who are experiencing more chronic and likely more severe physical and mental health issues. Other groups are referring to these measures more often as well. So this graph is not specifically from our data, rather from NIH data, but it does illustrate the consistent rise in prescription drug overdoses over the past decade and a half. In the past, we've reported on the number of deaths due to drug poisoning per 100,000 population based on 7 years of data. But despite using multiple years, there are still many counties where we could not get reliable estimates. This year, we now have modeled estimates of drug overdose deaths for every county. To provide estimates for all counties, the National Center for Health Statistics employed modeling procedures that borrow strengths across counties to generate single-year estimates of drug death rates, even where data was sparse due to small population size. These estimates provide counties with a range of values that represent the likely rate of death due to drug overdoses. However, as with all modeled estimates, there are likely to be counties whose actual value may be substantially different. In addition, the ranges provided give very truncated estimates for counties with higher death rates. The highest range includes counties with drug death rates for 20 or more per 100,000 population. But according to the unmodeled drug overdose death rates that we use, some counties actually have rates above 80. So we are continuing to provide unmodeled data as well. Another new measure is residential segregation. Residential segregation refers to the degree to which two or more groups live separately from one another in a geographic area. We are including this measure because residential segregation of blacks and whites is considered to be a fundamental cause of health disparities in the U.S. and has been linked to poor health outcomes, including infant and adult mortality, and a wide variety of reproductive, infectious, and chronic diseases. The United States has a long history of policies and practices that have promoted residential segregation of minority groups, such as blacks from whites. Although most overtly discriminatory policies and the institutional practices promoting segregation have been illegal for decades, segregation caused by racism still exists in many parts of the country and continues to have lasting implications for both individual and community well-being. If you want to read more about how segregation impacts health, we're chatting out 3 references that you might want to take a look at. Although there are many different ways of measuring segregation, our measure is called the Index of Dissimilarity, a demographic measure of the evenness with which 2 groups, Black and white residents or non-white and white residents in our case, are distributed across the sub-areas, census tracts in our case, that make up a larger area, counties in our case. Our index can be interpreted as the percentage of either Black or white, or non-white or white, residents that would have to move to different census tracts in order to produce a distribution that matches that of the county. Okay, this measure can be a little bit confusing, so I'd like to use a very simplified example to illustrate. Imagine a county where there are 100 restaurants, or sorry, 100 residents. Okay, and there are 2 neighborhoods in the county. In that county, there live 50 Black residents and 50 white residents. Neighborhood 1 is 80% Black and neighborhood 2 is 80% white. In this example, if 30 out of 50 or 60% of white residents moved from neighborhood 2 to neighborhood 1, both neighborhoods would end up with equivalent distributions, half Black and half white. So the index of dissimilarity, again, is the percentage of populations who would have to move in order to create this equivalent distribution, and in this case, they would be 60. So you can see here that in the first case, we have a relatively highly segregated group of neighborhoods with an index of 60 that move to complete integration, where the index would equal 0. Okay, this is another one of those slightly complicated measures, and if you want to review this again, it'll be posted later this week, and feel free to come and take a look at this again. For now, let's move on to insufficient sleep. Sleep is an important part of a healthy lifestyle. Sleep plays a key role in maintaining proper growth and repair of the body, learning, memory, emotional resilience, problem-solving, decision-making, and emotional control. A lack of sleep can have serious negative effects on health. Ongoing sleep deficiency has been linked to chronic health conditions, including heart disease, kidney disease, high blood pressure, and stroke, and psychiatric disorders such as depression and anxiety, risky behavior, and even suicide. Insufficient sleep is the percentage of adults who report sleeping less than 7 hours per 24-hour period in each county by the question, on average, how many hours of sleep do you get in a 24-hour period? Think about the time you actually spend sleeping or napping, not just the amount of sleep you think you should get. I just want to note the map that we're showing here is from the CDC and is of sufficient sleep, but you get the idea. And our measure is of insufficient sleep. Okay? Okay, so we're ready now to take some questions. So please feel free to post any questions that you have. We'll take those we can now, and then later this week, we'll post answers to any questions we're unable to address today.
All right, so first I just want to say thanks to Amanda for doing a great job walking us through some big changes this year, and shout out to the data team for doing a great job both getting some new information and working through the BRFSS changes. I'm just giving Amanda a minute to take a drink and a deep breath. That was a lot of talking. So we do have some questions coming in. The first one is, you mentioned that we shouldn't look at the total changes or the year-to-year changes in the release this year for the BRFSS measures. Are there any measures that we can look at the change over time?
Thanks, Kate. Sure. We have a lot of measures. I think there'll be 12 this year that we make trend graphs available for. On your snapshot, there will be a little figure that shows whether you have positive trends, unchanging trends, or negative trends for many of our measures. Any measures for which we have enough data that's comparable year to year, we provide that information for. So hopefully you'll take a look.
All right, fantastic, thanks. So another question related to, I think, some of the BRFSS data. Anyone looking for a challenge, say BRFSS 5 times fast or even just 1 time slow. Okay, so why do we look at adult smoking and adult obesity and we don't reference child obesity and youth smoking rates, since that would be a better predictor of future outcomes?
Hi there. Yeah, that's a great question. We would love to measure childhood obesity and smoking rates, but unfortunately we do not know of any data source that creates county-level rates around the country of those estimates. Childhood risk factor data is usually available from a survey called the Youth Risk Behavior Survey, and it produces it produces national and state results, but as of yet hasn't been producing county level results. In many cases, in states, they do child health surveys that end up producing estimates of youth smoking or obesity, and where possible, we try to provide links to those on our state data resources. So when you're on our website next time, try and take a look at those. You might find that your state produces regular estimates of those youth risk behaviors.
All right, great, thanks. That's a question we get a lot, so I think great to get an answer for that one. So we have another question from Jessica around the drug overdose deaths, and she's wondering if the drug overdose deaths only include those that are caused by prescription drugs.
Thanks, Jessica. That is a great question. No, actually, our measure includes any illicit or prescription drugs, so opioids, both illegal and prescription, and stimulants, or and any other of the prescription or illicit drugs that can cause overdoses. So no, there's no limitation on just prescription drugs. And we know that drug overdose deaths rises, yes, are happening due to prescription drugs, but there are other drugs. For example, the rise in heroin overdoses has also been increasing quite dramatically in many states, which is why we include all of the drugs.
All right, thanks for the clarification. All right, we have a question from Richard, who seems to have some keen eyes, wondering about, are the years of data collection on the slides those that have been used for the 2016 rankings? And I'm wondering if maybe we can just talk about where people can find out about the years of data that we will use in the 2016 rankings.
Yeah, that's right. The data the dates that we included ones that we intend to use in the 2016 rankings, and you'll be able to find out. We'll have on the release day documentation of all the measures, including their data source and their years, along with a lot of descriptive statistics about the measures, and of course our usual documentation about why we include them and where we get them from. So I hope that answers your question.
Yeah, I think so, and I think that's another common question we get a lot is the years of data used. So again, if you have trouble finding that, let us know when you see the new information and we can help you do that. All right, lots of questions coming in. So first, Amber says the new information is great, so I'm glad you think so. When using this for comparison, how much of an impact are the changes going to have on the 2016 rankings versus previous years?
That's a little hard to quantify, but I think you can say that overall you're going to expect to see a little more change than usual. Even if all we were doing was adding 5 new years of BRFSS change, you would probably see a little less stability in the rank estimates. There'll be more movement, again, in the middle of states, a little more stability around the very top rank and very lowest rank counties. But you definitely will see an impact here. So this will be, I feel like I've been doing this for a few years. We have some years where there's relatively large changes and some years a little less so, and I think you'll see a little more this year.
I think that's another good reminder of why really looking at your data and using that as the judge and not so much the movement from year to year is a really good thing to keep in mind, especially this year. All right, another question related to the drug overdose deaths. Will that measure the drug overdose deaths take into account years of life lost?
Oh. Hi there. That is, well, not in the same way that our measure of premature death takes into account years of life lost. We don't add up, how much younger the person was than age 75 in order to calculate these estimates. That is technically feasible, just not from the data we have actual access to. So that's a great idea. I think communities would find that very useful, and working with your vital statistics in your state, that could be some very powerful and good data for communication purposes.
Another good example of using the rankings data as a starting point and then drilling a little bit deeper into your local community data. All right, staying on this topic, are the overdose deaths accidental and intentional or accidental only?
All deaths due to any intentionality are included. So it could be accidental and intentional or of unknown intention. They're all included in this. We know that with increasing access to prescription drugs, both and illicit drugs, that deaths due to either of those causes increase. So we include all the causes of death here.
All right, we still have, sorry, we're just sifting through lots of good questions coming through. Some are a bit more specific to individual communities. Let me take a look at this one. So can you talk a little bit more about, I think one thing that you mentioned in the webinar that that we've been asked about a lot in the past years is the comparing counties across state lines. Can you just reiterate what that is again?
Sure, Kate. So we rank within states. We do this for a number of reasons, but it doesn't mean that for many communities, comparisons across state lines aren't important for them to understand their data. In some cases, the communities right across the state line are the most useful comparison for them, or the most comparable county. We make every effort to try to find measures that are easily comparable across states, and at this point we've gotten to where the vast majority of our measures are pretty easily comparable across state lines. There are a few for which we still have some reservations. In some cases, our measures are modeled in such a way that they include state-level effects that make border counties look a little more different than they might be in reality, or the measure is collected in slightly different ways across state lines. There will be summary information on our website about where to be a little more cautious in where you compares data across state lines, but we're really hoping that for communities this is a very useful tool for them.
Great, thanks. I know there's going to be a lot of counties that are excited for that feature, but looking for a bit of clarification. Okay, we're going to change gears a little bit. Any changes coming to the evidence ratings and what works for health?
Well, that is a great question. I am not quite sure about that. Kate, are you aware of any changes coming?
You know, we update. I will do the broad answer here and say every year we do make updates to what works for health as well as the roadmaps to Health Action Center. We make sure that there's, based on feedback that we get from the communities we're working with, some either updated features for ease of use or additional information available. So I think the What Works for Health question definitely would be good for our What Works for Health team, but definitely stay tuned for some updates to the Action Center as well. So those are all things that will be available in the 2016 release. I think sometimes we get really excited about the data that we forget about the other resources that go along with it. But certainly we do updates to each part of the website to bring you new and better information across the board. All right, so back to some data stuff, since that's what we're talking about today. Sorry for the curveball, Amanda. Any indication of inclusion of the negative health effects of secondhand smoke?
Well, certainly our model attempts to account for not only the individual smokers' level of health effects. Our smoking is rated quite highly. It has a weight of, I think, 10% within the model, which means we recognize it as a very important predictor of premature death in communities, and we know that a great part of that is secondhand smoke among non-smokers. So we don't do any particular measurements of the amount of secondhand smoke that people receive, but we certainly understand and include that in our weight for the importance of smoking as a health factor.
All right, staying on the data theme, how will the new drinking water measure be included in the county ranking calculation? And I was actually curious about this one too.
Yeah, that is an interesting question. So measures, I don't want to get too technical here, but in essence, yeses will be captured as ones and nos will be captured as zeros. State averages will be the percentage of counties that have a yes value, and then z-scores are able to be calculated from those. But you'll note that every one has the same z-score and every zero has the same z-score in your state. So there's a little less variation, no, actually a lot less variation in the z-scores in this value. Drinking water violations don't have a particularly high weight, so you shouldn't see a lot of change in your overall health factor due to the changes in the calculations in this measure.
Great, thanks. All right, another question going back to the BRFSS. That is a tongue twister of the day. Will additional details of how the BRFSS modeling was done be available, and especially what demographic factors were used in the model?
Hi there. Yes, there will be full citations of articles that were published about this methodology, as well as a longer explanation of this in any of the BRFSS measures in their data source tab. You're going to find lots of information about these changes and what they mean. There'll be an FAQ on our site, and we'll have links to, again, like I said, the original research that helped create these estimates.
All right, so hang on, I'm just looking. It looks like we still have some questions that are pretty individual specific, so we won't take those online. We do want to make sure that we have time to wrap up and get you information about some more upcoming webinars and other ways to access some information and connect with us so that you can continue to ask more questions and learn about the information we have.
Okay, so I hope you enjoyed this webinar and feel like you learned some more about the rankings, measures, and methods. Please join us for some upcoming webinars as well. On March 8th, we're offering a webinar on community engagement for health equity, racial, and social justice. And then after the rankings, on April 5th, we'll be offering a Rankings and Roadmaps 101 that will include an in-depth website tour of the 2016 website. So those might be great resources for you to check out and go sign up for those webinars. And in addition to that, please stay connected with us. You can follow us on Twitter, you can join us on Facebook, or you can subscribe to our e-newsletter. I know that at one point in the webinar I mentioned a Contact Us button. If you go to our website at www.countyhealthrankings.org, you're going to find a big orange button that says Contact Us all over, and we'd be happy to respond to any questions you might have. We'll get you in touch with the right people. So I hope you got all the information you needed, and I guess maybe we have one more thing before we head out, so just a sec.
Yep, I have one more question for you and then one more announcement because a good one just came in, again, related to our favorite acronym of the day. So given the new additions you mentioned and the changes to the BRFSS data, is it actually good or helpful to compare ranking from year to year, or best to view rankings only as the snapshot for this year?
So every year we really recommend that you view this as this year's snapshot. Comparing ranks from year to year is just not the most helpful way of understanding the way that health changes in your community. For that, we try to provide, like I said, the trend graphs where available. We only include those when we have several years of non-overlapping data, but for some of our other measures, you can also compare from year to year. But I think when you talk about comparing ranks, there's many things that go into it. It's not just your county's health, it's also the counties around you, the counties within their state, and you could be making great strides in your community and not always see it reflected in all of your health rankings. So definitely when you're comparing year to year, you want to look at your measures.
All right, thanks for taking one more question. It was just such a good one and one that comes up a lot, so I wanted to make sure that we got that one in today. We also have a question of just a reminder about when the rankings will be released this year. The date is March 16th, so just over 2 weeks out. Yeah, coming quickly. So then you'll be able to see your new snapshots with all this new information. And again, use it as an opportunity to start and broaden the conversation about health in your community.
Okay, thank you so much for joining us. It was great getting to talk with you all about this year's rankings. We're really excited about it, and I hope you are too. So have a good rest of your afternoon, and we'll see you on March 16th.